This is a presentation on surgical and therapeutic management of Scheuermann's kyphosis. Scheuermann's kyphosis is idiopathic without a gender specification. The age ranges are from 12 to 17. Instances ranges from 1 to 8%, and it can have a genetic predisposition. For the diagnosis, there needs to be a radiographic finding of vertebral wedging of 5 degrees or more on 3 adjacent vertebral bodies, end plate changes, and disc narrowing. The clinical presentation for Scheuermann's kyphosis is that the kyphosis is rigid and postural. They have rounded shoulders with a forward head, tight hamstrings, hip flexors, suboccipital muscles, and tight pectoral muscles. They have a negative neuroscreen, a positive Adams forward bend test, and the pain is generally gradual, located over the deformity, non-radiating, and worst at the end of the day. The two treatment options that we're going to discuss today are surgical and non-surgical.
Conservative treatment options include exercise and physical therapy and bracing or serial casting. Indications for conservative treatment are a skeletally immature patient. For the exercise and physical therapy category, the kyphotic curve needs to be less than 50 degrees. For the bracing category, kyphotic curve should be less than 70 degrees and or having individual vertebral wedging of less than 10 degrees. The goal of non-surgical treatment is to control the deformity and or prevent further. Exercise and physical therapy includes postural training, pectoralis and hamstring stretching, abdominal musculature strengthening, and to relieve lower extremity control. The benefits of exercise are that it prevents further progression of the kyphotic curve. Exercise and physical therapy has not been shown to lessen the kyphotic curve, so it prevents it from getting worse, but doesn't necessarily make the curve itself get better. Also, patient education, it increases the patient's awareness of the condition and also can decrease the associated back pain. Bracing is an effective treatment for skeletally immature patients. The purpose and goals of bracing is a permanent reduction of the kyphotic curve. So unlike physical therapy, bracing can reduce the curve. Bracing should start before the curvature angle exceeds 55 degrees in skeletally immature patients, and brace compliance is really important. The kids have to be wearing the brace for the changes to occur. There are several different bracing options. Milwaukee brace is one that's been used for many years and it's been proven to be really effective. There's Kyphologic brace, which is a newer, more modern brace that's similar to the Milwaukee brace and highly similar in brace correction, but uses less material for the brace, therefore increasing patient compliance. Serial casting is another bracing option if bracing itself has not been proven to be effective, and it's a more permanent correction. The results of bracing for patients with a kyphotic curve between 55 and 80 degrees and before skeletal maturity, there is success with bracing. A kyphotic curve of greater than 80 or a skeletally mature patients, there's no improvement with bracing or casting. Long-term follow-up studies showed that bracing reduced the kyphosis by an average of 11.9 degrees. There are a few complications of bracing. One, again, is the compliance issue. Also, there are psychological issues with self-image, and there's a probability for developing low back pain as bracing time increases. There's a small improvement of curvature long-term, but it's not significant.
From the research, there's only one clear indication for surgery, and that's a neurological complication or upper motor neuron signs. The surgery can also be considered and be talked about between the patient and the surgeon if there's a documented progression of the kyphosis, if the kyphosis is greater than 70 degrees, if the patient has pain that has not responded to conservative treatment, and if there are respiratory problems because kyphosis has gotten greater than 100 degrees. There are two different main types of surgery. The first is anterior-posterior fusion, and this is the type of surgery that has been going on for quite a while. It can be staged so that the anterior release is on one day and the posterior fusion is on another day. And the anterior release can be done via open thoracotomy or video-assisted thoracoscopic approach, or VATS. After this type of surgery, there needs to be bracing for about 3 months, and after 67.5 months, it was found that there was an average 3.1 degree loss of correction. This type of surgery also requires a rib graft for the anterior release and an iliac crest allograft for the posterior fusion, so it is quite invasive and there is a lot of recovery that needs to be done after. The posterior-only pedicle screw fixation is a newer type of surgery. The posterior-only type of fusion has been going on for a while. However, the pedicle screw part of the surgery is more of a newer technology, and it doesn't require bracing after surgery. There's less operating time and less blood loss in the anterior-posterior fusion, and there are less complications than the other type of surgery. There is found to be a 3.2 degree loss of correction after 31.7 months, and this surgery only requires an iliac crest allograft. Here is another comparison of the two types of surgery from a different article. You can see it reinforces the same points, that the anterior-posterior fusion requires more surgery time, has more blood loss, and it provides about the same amount of correction as the pedicle screw construct does. However, there are much fewer complications with the pedicle screw construct. So there are a few complications that can arise from surgery. One big one is junctional kyphosis, and this is when there's a kyphosis that occurs above the first level of fusion or below the last level of fusion. And if this occurs, surgeons may be required to go in and extend the fusion up to that level. Also, pleural fusion and pneumothorax can occur, and wound infection is another big one, and it was found in one article to be the most frequent complication of surgery. Also, spinal cord injury can possibly occur, however, it's very rare. According to Lowe et al., an adolescent whose kyphosis is less than 70 degrees should consider conservative treatment and bracing to fix their kyphosis. For most cases of kyphosis greater than 70 degrees, posterior-only thoracic pedicle screw fusion provides an average of 51.8 degree correction of kyphosis while minimizing complications. However, since no long-term studies have been able to be done on using posterior-only fusion with pedicle screw fixation, the long-term effects of the surgery are unknown. For Scheuermann's kyphosis, early detection and bracing with physical therapy is the recommended first-line treatment for skeletally immature patients. If conservative treatment with physical therapy and bracing is not successful, posterior-only fusion with pedicle screw construct surgery can provide a significant correction of kyphosis.
Here are some references if you would like to learn more about Scheuermann's kyphosis.